Good evening, everyone, and I hope that you don't mind being just the two of you. But anyway, we're going to do this for the video recording, which will be distributed to the others that have signed up. Once again, welcome to the Pharmacology NCLEX series. Today, we're going to have a discussion on oral hypoglycemics. The reason that I chose these sections of pharmacology is because they are the most common drugs that come out in the NCLEX. So we talk about antihypertensive drugs. And then yesterday we talk about anti-COPD as well as asthmatic drugs. And today and tomorrow we're going to deal with drugs that deal with diabetes mellitus. So let's begin our discussion with a pathophysiology or an overview of diabetes. So when we talk about diabetes, what is it? Well, it actually is a group of metabolic diseases, and these usually are characterized by hyperglycemia. And the reason why there is hyperglycemia is because there's defects in either the secretion of insulin or the action of insulin, or both. So whenever a patient is diabetic, the chronic hyperglycemia is associated with long-term damage, and sometimes it leads to failure of organs, especially the eyes, the kidneys, the nerves, the heart, and the blood vessels. So we'll go now to the pathophysiology of type 2 diabetes. And the reason why we focus on type 2 diabetes today is because oral hypoglycemic agents are only utilized for patients who have type 2 diabetes. So this type of diabetes is, again, characterized by insulin deficiency, as well as insulin resistance, and sometimes it's because of an increase in the glucose output of the liver. So those are the main things that happens with type 2 diabetes mellitus. So how do we establish the diagnosis of diabetes? And this is the things that are important. And an elevated blood glucose in and of itself is not going to be diagnostic of diabetes. However, a fasting glucose of greater than 126 milligrams per deciliter is going to be a significant finding. So that 126 as a fasting blood glucose is going to be significant. And other diagnostic measures that we do would be a 2-hour post-prandial during a 75-gram oral glucose tolerance test. And anytime the oral glucose tolerance test is about 200 milligrams per deciliter, then this establishes also a diagnosis of diabetes, or perhaps a random glucose of 200 milligrams per deciliter with classic signs and symptoms of hyperglycemia. And throughout all of these, we also establish the hemoglobin A1C levels. If the A1C levels are going to be above 6.5%, then this also is going to be a reliant diagnostic measure for diabetes mellitus. So what I want you to remember is this elevated fasting blood glucose of 126 and a hemoglobin A1C of 6.5. So those are the important parameters for the diagnosis of diabetes. So let's take a look at the pathophysiology of diabetes. We cannot talk about diabetes without talking about the organ that is responsible for the release of insulin. So this is the pancreas. The pancreas is an organ that is located near the stomach. And it is an exocrine gland, but also exocrine, meaning to say that it releases digestive enzymes, but it also has an endocrine function. The endocrine function is, of course, the release of insulin. So the working horse, the cells that are working the most are the pancreatic islets. And these are the cells known as the islets of Langerhans. This is the old name. And their purpose is to secrete glucagon and insulin. So there are two things that are going to be released from these pancreatic islets, and they are either are going to be glucagon or going to be insulin. So what is the role of glucagon? Well, glucagon plays a very important role in blood glucose regulation because whenever there is a decrease in blood glucose levels, what's going to happen is glucagon is going to be released. Now, on the other hand, insulin is going to be a counterbalancing hormone. And whenever there is an elevation of blood glucose, insulin is going to be stimulated to be released. So these are the two important endocrine functions of your pancreas. So why is it that there has got to be a balance between insulin and glucagon? We have to have good regulation as far as insulin and glucagon is concerned. So let's take a look at glucose first of all. Glucose is the preferred fuel for all cells. And this glucose is derived from the breakdown of carbohydrates and also foods and drinks that we consume. And this carbohydrate, again, is going to be transposed into glucose. And the glucose that's not immediately taken up by cells for fuel, so one is going to be for fuel, the others are going to be stored. So whatever is not used is going to be stored in the liver as well as in the muscles. And the way in which glucose is stored in the liver and the muscles is in the form of glycogen, or it could also be in the form of triglycerides. So the glycogen is stored in the liver and muscles. The triglycerides are going to be stored in the adipose tissue. So hormones are going to regulate both the storage and the utilization of glucose as required. And there are receptors located in the pancreas that senses whenever the blood glucose are going to be low. And therefore, what's going to happen is it's going to stimulate the pancreatic cells to secrete glucagon and vice versa. If there's too much sugar, then the pancreatic cells are stimulated to secrete insulin. Okay, so those are the roles and the regulation of blood sugar by insulin and glucagon. Let's focus a little bit on glucagon. So whenever we are fasting, such as during periods of prolonged labor or exercise or a long period of time that we don't eat, what's going to happen is that there's going to be a decline in your blood glucose. So in response, the alpha cells of the pancreas are going to secrete glucagon. So again, the cells that are responsible for releasing or stimulating the release of glucagon are your alpha cells. So what are the effects when glucagon is secreted? Well, first, it stimulates the liver to convert the stores of glycogen back into glucose. And this is known as glycogenolysis. So you remember that stored glucose in the liver. So this one is going to be broken down from the liver and it is now going to be converted back into glucose. So the glucose is then released into the circulation for use by the body cells. Now, the other action of glucagon is it stimulates the liver to take up more amino acids from the blood. So amino acids are going to be taken in by the blood, and then it is converted into glucose. This occurs in the liver, and this is what is known as gluconeogenesis. Gluco meaning sugar, neo new, genesis origin. So we're now utilizing amino acids from the body that is going to be converted into glucose. And the last function of glucagon is it stimulates lipolysis. What that means is it breaks down the stored triglycerides. You remember that stored triglycerides that we had? Well, it facilitates the breakdown of those triglycerides into free fatty acids and also glycerol. And so this is going to be converted to the liver and converted eventually into glucose. So this is what's called lipolysis, the breakdown of triglycerides. So taken together, these actions will increase blood glucose levels. So always remember that the glucagon is the one that is going to be responsible to maintain our blood sugar in times of fasting or in times of prolonged exercise or prolonged work or labor. So that's the function of glucagon. So now let's take a look at the function of insulin. So what does insulin do in the body? Well, insulin is very important because it facilitates the uptake of glucose into the skeletal and body tissues. So when these are the cells, for example, glucose is not able to go into the cell without the passive transport of insulin. So insulin is going to be necessary in order for this glucose to enter into the cells. So the presence of food in the intestine, for example, is going to trigger the release of hormones. And this in turn triggers insulin production and secretion by the beta cells of the pancreas. So the beta cells of the pancreas are the ones that are going to be responsible for releasing this insulin. The other thing is that insulin triggers the rapid movement of glucose into the cell membrane, as I had described over here. Another thing that insulin does is it reduces blood glucose. And it does this by stimulating glycolysis. And glycolysis is different from gluconeogenesis in that it is going to be the metabolism of glucose. And whenever we have a glucose as a fuel, then it's going to cause it to release ATP. And ATP is going to be necessary for energy. The other things that insulin does is it stimulates the liver to convert excess glucose into glycogen for storage. And it is going to inhibit enzymes that are involved in glycogenolysis, or the breakdown of glycogen. And the last role of insulin is to promote triglyceride and protein synthesis. So when insulin is secreted, it is actually regulated through a negative feedback mechanism. So when blood glucose levels decrease, further insulin release is inhibited. Now, this chart describes exactly how the body regulates blood glucose levels. So let's take a look at if the blood glucose concentration is usually going to be maintained at a level between 70 milligrams per deciliter to 110 milligrams per deciliter. So this is the normal range of blood glucose in the body. So if the blood glucose rises above, so let's say that this is going to be like 160 milligrams, what's going to happen? Well, the insulin is released by the beta cells of the pancreas, and it now does these three things. Triggers the body cells to take up glucose, inhibits glycogenolysis, and inhibits gluconeogenesis. So now the blood glucose decreases and we're back again to homeostasis. However, if the patient or the person develops hypoglycemia or a low blood glucose, what's going to happen is that there's going to be stimulation of the alpha cells, and glucagon is going to be released. And the action of glucagon is it inhibits body cells from taking up glucose. It stimulates glycogenolysis. That means to say that glycogen in the liver is broken down. And also it stimulates gluconeogenesis, meaning to say that amino acids and free glycerol are converted to glucose. So that responds in turn in increasing the concentration of blood glucose to maintain it at 70 to 110. Okay, so that's a simplification of the physiology of insulin and glucagon. So I have a first poll. So let's go to the first poll. Okay, so that's exactly the correct answer. 6.5 is the correct answer. Above which value of A1C means you have diabetes? And the answer to that is 6.5. Okay, so when we're dealing with drugs, we're talking about drugs to manage diabetes type 1, which we will be discussing tomorrow, not today. And these include your insulins. But today we're going to talk about these medications that are going to treat or to manage type 2 diabetes mellitus. So currently, there are 5 distinct classes of hypoglycemics available. As you could see over here, this is 1, 2, 3, 4, and 5. Okay, so each class displays unique pharmacologic properties, which we will be talking about. And these classes are your sulfonylureas, your meglitinides, right over here, your biguanides, and your thiazolidinediones, right over here. And of course, your last one would be your alpha glucosidase inhibitors. So we're going to be talking about these drugs very in detail so that we can understand how they act and how they are managing those people with diabetes type 2. Now, basically, when we're talking about oral hyperglycemic medications, they actually are of two types. One is either to increase the insulin release or secretions, and they would be called insulin secretagogues. So this would include your sulfonylureas as well as your meglitinides analogs. And the other one is insulin sensitizers. So this means to say that they don't act directly by stimulating the release of insulin, but rather they act in different areas. And this includes your biguanides as well as your thiazolidinediones. And of course, the last group, which are glucosidase inhibitors, may do both. Okay, so let's now go to the first drug. And this first drug is biguanide, also known as metformin. So metformin is the first-line oral drug of choice in the management of type 2 diabetes across all age groups. So if you have diabetes, type 2, it's most likely that the first drug that will be given to you would be metformin. So how does the biguanides or metformin work? Well, they lower blood glucose levels by decreasing the amount of glucose the liver produces and releases into the bloodstream. It does so by inhibiting gluconeogenesis and opposing the action of glucagon. The other thing is that they also help lower blood glucose levels by making the muscle tissue more sensitive to insulin so that it can absorb glucose for energy. So in order to understand that about increasing the sensitivity of muscle tissue to insulin, we have to remember that diabetes could be caused by either a decrease, type 2, a decrease in the production of insulin, or there could be enough insulin, but the problem is that they have faulty receptors. And these faulty receptors are also known as resistance to insulin. So in here, as you could see, metformin is going to increase the muscle tissue sensitivity to insulin so that it could absorb the glucose for energy. Now, notice that it does not increase the secretion of insulin. So therefore, it does not produce hypoglycemia. This is a very important thing about metformin. And this is the reason why it is the drug of choice in patients with type 2 diabetes mellitus. So the brands for metformin or biguanide could include your glucophage, your Glumetza, Fortamet, or Riomet, being glucophage being the most common and the most popular of all these brands. Okay? All right. So let's take a look now at the important things that you need to remember about metformin or your biguanides by talking about the common adverse reactions. So what are the common adverse reactions? Well, GI symptoms, a metallic taste, and weight loss. And I underscored this weight loss. I put a yellow highlighter on it because metformin actually is used by many people to lose weight. This is not an approved use of metformin, but nonetheless, people abuse this by using it to lose weight. Okay. And the other thing that is important to remember is that the use of metformin causes a consequence loss of B12 and folic acid. And therefore, we need to make sure that we monitor for B12 and folic acid deficiency. So this is also a very important side effect of metformin. And then, of course, the lactic acidosis. I know that you have heard about lactic acidosis in patients that are on metformin, but actually this complication is rare. But of course, although it's rare, it's very serious, and it can occur due to accumulation of metformin when there is going to be a renal dysfunction, and also if the patient is old. So therefore, what happens is we want to make sure that we always warn these patients to be mindful of the signs and symptoms of lactic acidosis. Now, lactic acidosis occurs as a result of renal dysfunction, and also it is going to be important to monitor the hepatic function of in patients that are receiving metformin. Now, the reason why the liver or liver enzymes are going to be very important is the liver is the one that is the organ to clear lactate, and therefore metformin should be avoided in patients with hepatic disease. There's a black box warning against the use of metformin, and that is in persons older than 80 years of age. They should not be used. And the reason for that is because of the risk for lactic acidosis. Okay, so what is lactic acidosis? Well, lactic acidosis, I'm sorry about that, is going to be a form of metabolic acidosis, which is characterized by a marked increase of lactic acid in the bloodstream. So the signs and symptoms of lactic acidosis are going to include hypotension and bradycardia. And that's the reason why these patients are going to be critical, because of the hypotension as well as the bradycardia. Okay, so what are the nursing implications as far as metformin is concerned? Well, always advise the patient to take metformin with a meal. And they should not use alcohol, because the use of alcohol actually could cause hypoglycemia. Now, the other thing is that if a patient is taking metformin and they're scheduled for a procedure that requires them to be NPO, or a procedure that requires them to have a contrast dye, they should discontinue metformin at least 48 hours before the procedure. Okay, so let me just write that it should be discontinued at least 48 hours before the procedure. All right, so why is it that we have to discontinue it 48 hours before the procedure? Well, the reason why is because if they are not eating any food, they're not getting any glucose. And so to continue to take metformin would put them into a hypoglycemic state. Now, the other reason why, in contrast dye, when we use contrast dye for X-rays, it impairs, or it could impair, the function of the kidneys in some patients anyway. And therefore, metformin may cause lactic acid buildup with impaired kidney function. So that's why the two are not recommended together. And lastly, remember that patients may need to take a B12 supplement if it is indicated, as B12 and folic acid deficiency are common in these patients. Okay, let's go to another poll. Okay, so let's end the poll. You remember that we need to hold the dose, and the reason why we need to hold the dose and notify the doctor for further orders is because of the fact that it is going to, you remember that we are not going to be eating, we're going to be NPO. So therefore, this patient does not need the metformin because then your glucose is going to be decreased. So letter B is the correct response. So now we're going to talk about these medications that are listed over here. And so we began with metformin, and now we're going to go to the next one, which is your sulfonylureas. So sulfonylureas are those that end with the suffix "ide." And these medications are drugs that stimulate the pancreas to release more insulin. Because they increase insulin production, they're therefore going to be at risk for hypoglycemia. You remember in metformin, in biguanides, we do not have a risk for hypoglycemia. But in sulfonylureas, because you're now stimulating the pancreas to release insulin, you're going to have a risk for the development of hypoglycemia. Now, all sulfonylurea drugs have similar effects on blood sugar levels, but they differ in their side effects and interactions with others. So as you could see, the examples over here are glyburide, glimepiride, glipizide, and chlorpropamide. So they all end with IDE, okay? So remember them by their generic name rather than their brand name, because that is going to be easier to remember if you use the generic name rather than the brand name, okay? All right, so what are the side effects of sulfonylureas? Well, number one, all sulfonylurea drugs are capable of producing severe hypoglycemia. Hypoglycemia may be difficult to recognize in the elderly and in people who are taking beta blockers, because you remember the typical signs and symptoms of hypoglycemia may not occur. You might not see tachycardia, for example. And so therefore, we have to be mindful on patients who are taking beta blockers and at the same time sulfonylureas. Now, the other thing that must be remembered is that sulfonylurea medication should be given 30 minutes before a meal. Okay, 30 minutes before a meal because of its hypoglycemic effect. So the hypoglycemic action of sulfonylureas sometimes could be potentiated by certain drugs. And these drugs that potentiate the hypoglycemia are going to be your NSAIDs, your non-steroidal anti-inflammatory agents. And therefore, we have to be very mindful about that. Now, the use of sulfonylureas and alcohol can cause a disulfiram type of reaction. So what is disulfiram? Well, this is a medication that we usually use to support the treatment of chronic alcoholism. And what this does is that when a person drinks and they're taking disulfiram, they're going to have an acute sensitivity to ethanol. So they're going to have many effects of hangover to be felt immediately following alcohol consumption, and therefore they're not going to touch alcohol anymore. So that is exactly what they're going to experience if they drink alcohol while they are taking these drugs. Okay? And the other thing that is going to be important with these drugs is that it is a sulfonylurea. So it will be contraindicated for people who have a sulfa allergy. And another side effect I think that is important is the photosensitivity. Individuals who are going to be taking sulfonylureas are going to experience photosensitivity because their chemical structure, sulfonamide, is known to be a photoactive, which means that they're capable of a chemical or physical change in response to light. So that's why it is advised that they have to protect themselves against the UV rays. Okay. Okay, so the important word over here is what would cause concern. Which of the following statements made by the patient causes concern? So which means to say he would need further instruction, right? Okay. I will monitor my blood glucose regularly because I know this medication can cause a low blood sugar. This is a correct statement. I will consume no more than 8 ounces of alcohol per week. Oh, just meal. He's going to be drinking, and so he will have a disulfiram type of reaction. And of course, this is also a correct statement, and letter D is also a correct statement as well. So the one that is of concern is going to be letter B. All right, because these drugs are going to increase secretion of insulin, it's going to have the potential of causing hypoglycemia. And it usually is going to peak between 3 to 4 hours. You are correct. So it's supposed to peak in around 3 to 4 hours. And therefore, this is the time that they're most likely going to experience hypoglycemia. Okay, so similar to insulin, we have a peak effect. In this oral agents, you will also have peak effects. All right, so chlorpropamide ends with IDE, so which means to say that this is a sulfonylurea. Okay, so we have talked about biguanides as well as sulfonylureas. So now we're going to talk about meglitinides. And meglitinides are going to be the ones that end with glyinide. So the suffix are glyinide. Example of that is ripaglinide and nateglinide, Prandin or Starlex. So what are these medications? Well, meglitinides are rapid-acting oral antidiabetic agents, and they lower blood glucose, again, by stimulating insulin secretion from the pancreas. And therefore, this is going to be similar to sulfonylureas. So my question is, will these individuals be at risk for hypoglycemia? And the answer to that is yes. Okay, so meglitinides, the glyinides are going to be the same or similar as your ides. The mechanism of action of meglitinides closely resembles that of the sulfonylureas. Now, unlike sulfonylureas, the only difference is these drugs have a very short onset of action and a very short half-life. So that's the only difference between the two. Okay, so what are the side effects of these drugs? Well, again, because they're similar to sulfonylureas, hypoglycemia is going to occur. Now, you remember I said that they have a short onset of action, which means to say they're very quick, and they can act within 15 to 30 minutes. And so, what is the general consideration? Well, it is going to be important for the patient to be sure to eat immediately or to take it immediately close to a meal, right? Because of the risk of hypoglycemia. So we need to make sure that it is taken within 15 to 30 minutes. So this one and this one. Now, if they skip a meal, obviously they're not going to take this medication. Now, the other side effects is going to be headaches, dizziness. It also causes weight gain and GI disturbances such as flatulence and indigestion. The contraindication to the use of meglitinides is pregnancy and breastfeeding. And of course, if there is a thyroid, cardiac, or hepatic or renal disease, then it's also contraindicated. But I wanted you to remember the pregnancy for this one and the hypoglycemia. So the two drugs that causes hypoglycemia are your sulfonylureas, your ides, and your glyinides, your meglitinides. Okay? You are correct. I didn't mention this earlier, but metformin should never be given with milk or other dairy products because they counteract each other. Okay. All right, we haven't discussed this yet, but it's going to be coming up in our discussion. The correct answer here is your thiazolidinediones, or letter B. Okay, and I will explain that later on when we get there. I don't know why I had placed this in this particular part of the presentation. So we had already talked about biguanides, sulfonylureas, as well as meglitinides. Now we're going to talk about DPP4 inhibitors. They stand for dipeptidyl peptidase 4 inhibitors. And so let's take a look at these drugs carefully. So dipeptidyl peptidase 4 inhibitors, or the gliptins, are also going to be oral anti-diabetic agents. Now, what I want you to know is that DPP4 is an enzyme. And the purpose of this enzyme is it slows down the inactivation of incretin hormones. And these hormones are actually released along with insulin. And incretin is important in the sense that they decrease or inhibit glucagon release. They also increase insulin secretion. They decrease gastric emptying and decrease blood glucose levels. So all these are going to act indirectly. The enzyme DPP4, if you inhibit them, you're going to have more incretin hormones. And having incretin hormones, you're going to increase insulin secretion, decrease glucagon secretion, and delayed gastric emptying. So when insulin is released in the pancreas, another substance is also released, and those are called incretin. These are hormones as well. And so when you inhibit DPP4, there's going to be more of the incretin that's going to be available. So these medications are the gliptins. So when you hear of anything that ends with gliptin, then you are going to know that this is a DPP4 inhibitor. An example of that is sitagliptin, which is Januvia. So this medication is taken once daily, and it can be taken with or without food, but the three most commonly reported adverse reactions are going to be nasopharyngitis, as well as upper respiratory infection and headache. So this is the most common one, and we do not know why these individuals who use this are predisposed to upper respiratory infection. So that would include your nasopharyngitis as well as headache. The other side effects is going to be the risk of an increased risk of pancreatitis as well as UTI. Excuse me. And one thing that's interesting about this drug is it's weight neutral. It doesn't increase or it doesn't decrease weight. So it's weight neutral. And again, this medication, like the other drugs, do not have a risk of hypoglycemia. Okay, so DPP4 inhibitors, along with your biguanides, do not have a risk for hypoglycemia. Very good. It's obvious that when we have metformin, one of the complications that we think of always is going to be lactic acidosis. So if there's an increase in serum lactate of this individual, then it is essential to discontinue with metformin. It also is essential to discontinue metformin if there's renal impairment. Okay. All right, so we finished DPP4 inhibitors. We have finished biguanides, sulfonylureas, meglitinides, and DPP4 inhibitors. And now we're going to go to GLP1 agonists. So what are GLP1 agonists? Well, these are glucagon-like peptide-1 receptor agonists, and they usually end with tide. Now, what's the mode of action or mechanism of action of this drug? Well, this agent stimulates insulin secretion, and it inhibits glucagon secretion, which prevents more glucose from going into the bloodstream, and therefore it lowers down blood sugar levels. The action of these drugs is based on incretins, and incretins are gut hormones that work to increase insulin secretion in response to eating. So when we eat, there's going to be an increase in incretins. And these are hormones that work in several ways. They increase a feeling of fullness, and therefore, when you are only eating a small amount and you already feel full, you're not going to eat a lot, right? It also slows down stomach emptying, and it also increases insulin release. So these are the modes of action as far as this drug is concerned, and therefore, they decrease blood sugar levels this way. Now, these drugs are only used as a second or third agent. They're never used by themselves. And the main draw of these drugs is that they lead to weight loss in about a majority of individuals. And they curb hunger, making it a good choice for people who constantly feel hungry. So this causes weight loss, and therefore it's also a very good agent to decrease the weight of the patient, particularly if they're overweight. This drug is often used in combination with metformin, particularly when metformin alone does not sufficiently regulate the blood sugar levels. If for any reason an individual cannot take metformin, then GLP1 receptor agonists are going to be good substitutes. It's the next choice. Now, what is interesting about these drugs? These drugs are self-injectable, and the frequency of injection depends on the drug. Different drugs like your Victoza, your liraglutide, is once a daily injection. But Byetta, well, which is exenatide, and that is the most common one, is a twice daily injection. So exenatide is the most common of all these. So exenatide or Byetta. Okay. All right, so what are some of the precautions as far as GLP1 agonists or incretin mimetics are going to be? Well, remember that these are medications that is usually given as an injection, and it could be once a day or twice a day. There's also another drug that can be taken once a week only. Again, so the contraindications are going to be, of course, that if the patient is hypersensitive or the patient is pregnant, this is not going to be a drug for them. There's also a black box warning. If you remember the other day, I said that anytime there's a black box warning, you need to always remember that. And the black box warning to this one is, of course, to pregnancy and to breastfeeding. Now, the side effects, nausea is the main side effect. Others include vomiting and diarrhea. But the most serious but less common is going to be pancreatitis. So always remember that pancreatitis might be a complication in any of these, because you remember you're dealing with the pancreas. So it's always a good thing to always think about the possibility of pancreas problems with the pancreas whenever you're giving drugs that affect the pancreas. Okay, so the correct answer to this one is stimulates beta cells to secrete more insulin. That would be sulfonylureas, letter C. Okay, so we have to remember which one secretes or increases the secretion of insulin. And so it would be both your sulfonylureas as well as your meglitinides. Okay, so the ides and the tides are going to be the correct answer. All right, so we have talked about biguanides, sulfonylureas, meglitinides, DPP4 inhibitors, your GLP1 agonists, and now we're going to go to another one, which is the SGLT2 inhibitors. And this is going to act differently compared to the rest. Now, SGLT2 inhibitors travel to the proximal convoluted tubules in the kidneys. So they go into the proximal convoluted kidneys where they block the sodium glucose transporter, or SGLT2. Okay. The purpose of this SGLT2, by the way, is for us to conserve glucose when needed. So when you inhibit this, there's not going to be a conservation of the glucose, but rather you're going to ask the kidneys to remove as much as 90% of glucose from the body. So therefore, this particular medication is going to act in the kidneys. So it results in more glucose being excreted in the urine. So these drugs end with flozin. Flow, if you remember flow, like urine flow. So these drugs include your dapagliflozin, empagliflozin, or Jardiance, which is a very common one, canagliflozin, and ertugliflozin. So of all these, Jardiance is the one that's much more common, or empagliflozin. So remember that it is a drug that acts in the proximal convoluted tubules. So they end with flozin. So remember, flow, urine flow, it eliminates the glucose that is supposed to be reabsorbed. And it does that by inhibiting SGLT2. Okay. So what's so special about these drugs? Well, the major side effect is what is so special about this drug. And because now you're excreting a lot of sugar through your urine, what is the danger of that being the case? Well, if there's a lot of glucose in the urine, it favors microbial growth. For that reason, the most common side effect of SGLT2 inhibitors are urinary tract infection, particularly yeast infection, genital yeast infection. So always think about that. And also, the decreased reabsorption of glucose in the renal tubules increases urine osmolarity, and therefore it causes more water to be lost in the urine. So this results in urinary frequency or polyuria, and sometimes it might even lead to renal impairment. So we have to be mindful about this. So glycosuria, genital yeast infections, it could also cause hyperkalemia, polyuria, and dehydration. These drugs are going to also cause weight loss because you're going to be losing a lot of fluid. So those are the side effects as well as the implications. Now, remember that these medications are going to end with flozin. So flow is equal to the SGLT2 inhibitors. I think this is a repeat, right? Okay. So the correct answer is, we already did this, sulfonylureas and your meglitinides. Okay, so we have finished talking about biguanides, sulfonylureas, meglitinides, DPP4 inhibitors, GLP1 agonists, SGLT2 inhibitors. We're going to talk next about acarbose, thiazole, lidinayons, and amylin analogs. Now it's 7 o'clock, so let's just take a 5-minute break and we'll just discuss these 3 drug classifications last, and we will be done. Okay, so let's take 5 minutes. All right, it's 5 minutes, so let's continue. But before I continue, I want to thank you, Fran and Jan, for being so gracious to attend this class. When I volunteered to do this class, the dean told me that maybe there's not going to be many people that will attend live, but there will be more people that will be viewing the videos because a lot of people work. So I understood that. And so it's always nice to record something with some people, at least even if it's 2 people only or 1 person to talk to. So thank you so much for being with me. All right, so let's go to the next class of drugs that we're going to be using for patients that are type 2 diabetics, and they are the alpha glucosidase inhibitors. But before I go there, I wanted to tell you that the biguanides work by interfering with glucagon, right? The sulfonylureas and your meglitinides work by stimulating the pancreas to release more insulin. And the DPP4 inhibitors and the GLP1 agonists work in the gut. And the SGLT2 inhibitors work in the kidney. And now let's take a look at what acarbose does. Well, taken with the first bite of a meal, alpha glucosidase inhibitors are especially well suited to treat postprandial hyperglycemia, which is a rapid increase of blood glucose following a meal. And this is a common problem that many people with type 2 diabetes experience. So alpha glucosidase is one of the enzymes that is responsible for breaking down carbohydrates to sugar particles like glucose in order for the carbohydrates to be absorbed. So notice now that it works in the gut because the drugs prevent the immediate breakdown of starch into a simple sugar like a monosaccharide that usually is going to be absorbed into the bloodstream quickly. More of the carbohydrate that is consumed at a meal gets absorbed further down in the GI tract toward the end of the small intestine or the colon, and therefore not a whole lot of this carbohydrates are going to be absorbed eventually to be converted into sugar. So by slowing down the absorption of carbohydrate, it gives the beta cells in the pancreas more time to secrete adequate insulin to cover the meal. So this results in a smaller and slower rise in blood glucose levels following meals and effectively throughout the day. Okay, so again, it works in the gut. And these medications are medications that end with acarb, or begin with acarb, I should say. It should be the prefix is acarb, meaning to say absence of carbohydrates. And let me just go back here. As you could see, acarbose is going to be the most common here in the United States that we use, and miglitol is the other one. And this voglibose or advog is not used that much, but glycet and precose or acarbose and miglitol are the most common ones that are used here in the United States. So because it interferes with the absorption of carbohydrates and the conversion to glucose, the side effects, therefore, are going to be more GI. So you have flatulence, for example, GI symptoms and diarrhea. And there's one good thing about this too, is that because it slows down the absorption of carbohydrates, it's going to cause weight loss. So weight loss is going to be important in diabetes because most oftentimes diabetics are obese or overweight. And therefore, we always identify these diabetic drugs, whether or not they're weight neutral or they participate in weight loss or weight gain. Now, the contraindications of these drugs are any GI problems. Example of that is irritable bowel disease, ileus, or intestinal obstruction, because you're interfering with the absorption of nutrients in the GI tract. Pregnancy in children is also contraindicated. And because of the fact that we are going to interfere with the absorption of food, how many times will the patient take this? They have to take it 3 times a day. This is going to be taken with the first bite of your main meals. So breakfast, lunch, and dinner. Okay? Okay, so you remember that IDE and TIDE are the ones that are going to cause hypoglycemia, okay, IDE and TIDE. So acarbose is not going to cause a hypoglycemia because it works in the GI tract. And then, of course, metformin or biguanides are medications that are not associated with hypoglycemia when they're used alone. So acarbose and also metformin. Okay, so you remember that your SGLT2 inhibitors work in the proximal tubule of the kidney. So the correct answer is letter B. Okay. And let's go to UTI may be a side effect of which of these drugs? You are correct, yes. Your SGLT2s are going to be the ones that are going to increase the occurrence of UTI. Okay, so we have finished acarbose, and now we're going to talk about thiazolidinediones, TZDs for short, because it's so difficult to pronounce them. But anyway, these are drugs that are going to end with the suffix glitazone. So they're thiazolidinediones, and the way it works, it increases insulin sensitivity by acting on adipose as well as muscle, and to a lesser extent, the liver, to increase utilization and decrease glucose production. So this does not work in the gut, it does not work in the pancreas, but rather it works outside of it, particularly muscles and adipose tissue, as well as the liver. And they're sensitized, or they increase utilization and decrease the glucose production. So these medications decrease both fasting and rises of glucose following a meal by decreasing the insulin resistance and allowing endogenous insulin to be more effective. So that's the reason why they're called insulin sensitizers. So it decreases insulin resistance. Examples of this drug would be your pioglitazone or Actos, and this is going to be a very common drug, as well as rosiglitazone or Avandia. Okay, and these are the two drugs that are of this class. So what are the side effects of these drugs? Well, the major side effect is going to be weight gain. And of course, the other thing that is going to be important here is that in the beginning, patients who use this drug would develop liver dysfunction, and therefore it is going to be a major consideration that we monitor the patient for symptoms of hepatic injury. And when I mean hepatic injury, what are some of the signs and symptoms? Well, jaundice or a dark urine would be manifestations of it. It is possible that this particular drug can cause weight gain. And the reason why there's a possibility of increasing weight gain is because of possible fluid overload. So we need to make sure that we also are going to monitor these patients for signs and symptoms of heart failure, so fluid retention. Another problem with thiazolinidiones or glitazones are going to be an increase or propensity to fractures. So this is a big consideration, particularly in elderly. And rosiglitazone, unfortunately, has been found to increase cardiovascular risk, like, for example, myocardial infarction. And that is the reason why it is restricted. It is not used for patients who might have myocardial infarction or who has the potential of developing MI, such as patients with coronary artery disease. Yes, acarbose is the drug. It slows down and decreases the digestion of carbohydrates in the intestines, thereby reducing their absorption. And the word absence of carbohydrates, would be our clue as far as that's concerned. Oh, we already did this. I'm sorry. Okay, let's go to. Okay, so I already did the poll, so let's take a look over here what the correct answer is. The nurse is reinforcing teaching about acrobose to a client with newly diagnosed type 2 diabetes. Which statement by the client indicates a need for further understanding or a need for further teaching, I guess? Okay. So the correct answer here is letter A is the correct response. Letter B is also a correct response because GI symptoms are going to be very common in these patients. But this one, I must take this medication 1 hour before I eat. It's going to be too long. It usually is going to be taken 3 times a day with the first bite of the meal because the food increases absorption. So letter C is the correct response. All right, so we finished with thiazolidinediones. And so the last drug that we're going to talk about are the amylin analogs. Amylin analogs. Well, what is amylin? Well, amylin is an amino acid. So amylin is an amino acid. And this is a hormone that's produced by the pancreas, and actually it's released at the same time as insulin. So when insulin is released, amylin is also released by the pancreas. So these two are released together. And amylin is released, but in smaller quantities in comparison to insulin. And what does it do? Well, the hormone actually, amylin, assists insulin in controlling post-meal glucose levels. And how does it do that? It inhibits the release of glucagon. And also it slows down the emptying of food from the stomach. So if you slow down the emptying of food from the stomach, it therefore helps to prevent blood sugar levels from rising too much after eating. So these medications generally make people feel full longer, which can contribute to weight loss, which is also a good thing as far as use in diabetics as well as who are also overweight or obese. Now, these drugs are actually injectable drugs. So you remember the other kinds of injectable drugs that we had? Well, this is an injectable drug. They usually are going to be administered before meals. And of course, amylin is going to reduce the weight of the patient as well as slow down the emptying of food from the stomach. So by slowing down the absorption or emptying of the stomach, it also makes the patient feel full, and therefore it curbs the appetite. So your amylin analogs are going to be injected before each major meal. It cannot be mixed with insulin, so it means taking more injections. That's the disadvantage of this drug. Whenever the patient is also on insulin, it is going to increase the possibility of hypoglycemia. And that is one drawback of this drug. And the major side effects are going to be GI, in particular nausea. And that is the reason why the dose is usually started low. All right. Okay, I didn't talk much about this, but clients who take acarbose are advised to take the medication immediately with the first bite of each meal. And the major reason for that is this one, to prevent bloating and diarrhea. Hmm. 53. Very good. So in looking at this, we'll just look at strategy. And over here, it increases the insulin release. And because it's an insulin incretin mimetic, increased glucagon, that would increase blood sugar. So this should be decreased. This should be decreased as well. And protein building, it increases protein building. No, it would not. So letter A is the correct response. It's a incretin mimetic, and therefore it increases insulin release. It should decrease glucagon. It makes the patient feel full, and of course, it slows down GI emptying. So the correct answer is going to be letter A. Okay, I think that ends our discussion on oral anti-diabetic agents. So in this slide, you could see the drug classification as well as the mechanism of action. And so we have talked about alpha-glucosidase inhibitors, biguanides, sulfonylureas, the glutinides, thiazolidinediones, and DPP4 inhibitors. So this ends our discussion on oral anti-diabetic agents. Tomorrow we'll talk about your insulin for diabetes. So once again, thank you, Jan and Francis, for your participation. I hope to see you tomorrow. Have a great evening, okay? Thank you, Francis. Appreciate it. Have a great day. Yes, see you tomorrow.